A 46-year-old gentleman was referred to us with a suspected mass in the perigastric region on other imaging studies, and patient has some weight loss. And what we are trying to see now is a part of the duodenal anatomy. You can see the part of the pancreas here. So you can see the pancreas here, and we want to see there is some lesion which is arising very close. Is it congruent with the pancreas? And that is the important question. Are we dealing with a solid cystic neoplasm of pancreas? And that's the question. You can see this is a part of the pancreas, and I can see some cystic lesion very close to that part of the pancreas. We'll try and identify if there is a clear-cut demarcation between pancreas and lesion, which I will magnify and see. And we'll go to the 5 megahertz scanning to get a little deeper to the tissues. And you can see here that the pancreatic parenchyma and the lesion are congruent. So there is a very strong possibility that this could be a solid cystic neoplasm of pancreas affecting the genu onwards, the entire body and tail completely replaced. We will try and see that from the body of the pancreas, and that's exactly what we are seeing here, that I'm not able to see the body and the tail of pancreas separate at all. So you can see a huge solid cystic lesion here, and now I am right in the cardia. So the lesion is so huge that it is extending almost into the mediastinum. So I want all of you to kindly pay attention now. When I mark this, this is the aorta, this is the left crus of diaphragm, and this is the mass, part of it extending into the mediastinum as well. And then as you go down, it is right sitting on the area of the pancreas. And I'm trying to see if I can see a slice of pancreas. And unfortunately, I don't see any evidence of pancreatic tissue anywhere. The splenic artery and the splenic vein all are pushed back because of the size of the lesion. And we have been requested to have tissue diagnosis for this patient, and therefore we will now proceed with EUS guided FNA from the so-called solid cystic lesion of the pancreas. So there are only two possibilities here, either a very large gist lesion eroding into the stomach, but it's not very classical. We could not see pancreas so well. So my first diagnosis here would be a pancreatic lesion, unless proved otherwise. It's a huge 11 centimeters by almost more than 10 centimeters. And these are very large neuroendocrine tumors of pancreas, which we have seen sometimes. And I'm seeing the part of the pancreas. Here I'm seeing the part of the pancreatic duct here. This is the part of the pancreatic duct here. And there is a continuity of the pancreatic parenchyma. So this gives me a little more impetus to decide where to go exactly and where to puncture this lesion. I'm going to try and see the wall layers of the stomach, and you can actually see the wall layers fairly well. We'll inject some water to delineate for all of you to appreciate. Put some more water. it. So now we have some water as acoustic medium, and I'm going to magnify my picture, go to higher frequency at 10 megahertz and try and see whether this is part of the gastric wall lesion, because in such a large lesion it is extremely difficult to exactly identify whether this is arising from the muscularis propria because of the sheer size of the lesion. And that's what we will do now. We will magnify this and we will try and see the layers of the gastric wall. And you can actually see the changes of portal hypertension in a setting of such a large lesion, because I am seeing some varices, and I will show you in the wall of the stomach. You can see some abnormal vessels there. These are the left-sided portal hypertension related varices in the wall of the stomach. So you can actually see the varices there. So we will try and see the layers again very, very carefully. I can actually see all the layers here, but because of the sheer size, the stomach is getting little compressed. We will deflate and try and see the layers. And you are seeing 5 distinct layers here. More water, please. So we'll instill a little more water in order to distend the stomach a little more. That is required sometimes. And we make sure that the water is aspirated when you actually come out. So now I'm going to try and show you the layers of the gastric wall. You can see the gastric wall layers. And abnormal vessels running in the wall, leading to, these are all the varices. So I will show you, these are the layers of the, we will show the actual layers and then we will point out the variceal. Hold it. Yes. So you can see here, these are the layers. The mucosa, the muscularis mucosa, the submucosal layer is the vessel, and this is the part of the muscularis propria with the serosa. And you can see the vessels are traversing the submucosal layer. These are the classical varices. We call it the gastric varices. They will light up on color Doppler. You can see here. They are within the walls, so endoscopic ultrasound sometimes can be used to pick up portal hypertension as well. And we need to definitely rule out a mass in the pancreas here rather than a gastric lesion, because we have seen the layers of the stomach. We would like to go and take some tissue from the solids component of the lesion rather than going to the cystic spaces, because as we know, cystic neoplasm are more prone for infection. Studies have shown that. There are no lymph nodes which we have seen. We are going to see lymph nodes in the mediastinum. There are no nodes either. So now we'll proceed with the USFNA. Now on linear echoendoscopy, we are trying to target the lesion. We are scanning at 5 megahertz. Whenever we come across a large lesion, we prefer to start at a lower frequency to penetrate deeper into the lesion and adjust the depth of the focus as well. So I'm going to shift my focal length a little away. So I've shifted the focus all the way up to the periphery of the lesion, as you can see here. So we can see the entire length of the lesion, and I see a very large solid cystic space. I'm trying to look for a space where there is very little fluid. We want to have tissue diagnosis, and we also want to avoid at the same time patient has portal hypertension. So I will demonstrate to you when I say portal hypertension, these are the varices, probably secondary to the compression of the splenic vein. This patient has developed left-sided portal hypertension. So there are few abnormal vessels there, and we need to be careful when you do any USFNA. And actually here we can see the layers. So if you see this particular area, it gives an impression that the muscularis propria is flaring up here. And this gives an impression of a gist. But the moment I turn my scope a little bit away and get into the little perspective, I can see the muscularis propria running there. So you see the muscularis propria is running here, and this tells me that we are dealing with something which is extra gastric, and this is the muscularis propria running here. And therefore what I am trying to do now, there is a small fluid pocket as well, a very small amount of fluid, free fluid. Now whenever you have a free fluid in a neoplastic process, we are looking at a potential early peritoneal dissemination. And this is extremely important information which you will not get on any CT scan, MRI, PET CT. And therefore, we feel EUS is extremely helpful in evaluating the primary lesion, nodal status, as well as early peritoneal dissemination. So now we have adjusted our color Doppler signal. I'm going predominantly in solid substance of the lesion rather than going into the fluid part. So we'll just check our trajectory and axis, that we are not hitting any fluid part. Yes, we are not, because we want to have tissue diagnosis of the solid component of the lesion. So now we have our sheath abutting against. Color Doppler signal has confirmed there is no obvious vascular major vessel. There are few lighting up in this part. Neuroendocrine tumor may sometimes appear like this in pancreas, because they are known to be vascular. And now we will try and fix the outer sheath, and then with a staccato we'll enter the lesion. I'll just withdraw a little bit in the solid component, and the stylet is withdrawn after depugging. I'll try and withdraw a little bit, and without too much of jiggling movement, especially when you know there is a possibility of a vascular lesion. This is our technique, which I think will become more popular worldwide, rather than doing too much of jiggling in the lesion. I've been discussing this with some of the leading friends and experts of EUS across the planet, that there's no need to jiggle too much. Just be there. The respiration of the patient itself will do the jiggling for you. Just very gentle Withdrawal, very, very gentle withdrawal. Extremely gentle you have to be with the tissues, because if you respect tissues, tissues will respect you. And that's exactly what we are doing. Very gentle withdrawal out of the lesion. No rough movements. We don't want needle dancing in the lesion. It's good to see, but the yield may be very, very poor, because then you will put a lot of blood in your needle. So now we lock the syringe at this stage and gently withdraw the needle out. So now what we're going to do now is, I would like to chase one of the fluid pockets, which is not so small, not so big, and try and aspirate what we can out of it. And with the staccato, we'll try and go inside. Straight down in it. We'll take a sterile syringe and aspirate first to find out if there is a fluid which can be sent for exam. It's going down a little bit in size. You can see the size is going down. So that size is getting aspirated. And now I'll come a little bit in a solid component. Very gently we'll aspirate. That's the end of the procedure.